Okay, let's regroup. So last session, followed by the QA. So I'm going to be really applying some of the things that we've been hearing to the TMJ in particular, and TMJ problems are really common in people who are hypermobile, and fascia plays an important role for a couple of different reasons. So it really makes a great kind of case study of why fascia is important. This is me. You can read it another time. I do have handouts, and I have a handout that talks, I have a whole handout on the TMJ. If you want to scan the scan code, I will show that again at the end if you want to scan it there. But I have a TMJ handout that I give to my patients, and actually I've convinced all my dentists to give it to their patients who have TMJ problems. So if you struggle with TMJ problems, you can access that. And I have a bunch of other handouts as well. So the objectives today, to talk about the different types of fascia in the temporomandibular joint. That's going to influence the types of problems that we have with that kind of fascia. Talk about some of the factors that contribute to TMJ problems or TMJ dysfunction. In individuals with hypermobility, we're definitely at increased risk of having temporomandibular disorder. Describe a little bit of what it looks like, although I guess some of you probably know what it feels like, and a few strategies for how you can take care of it yourself, how you can prevent some of the problems, because of course prevention is the best strategy rather than fixing a problem that already exists. This is my overall approach to managing patients with hypermobility, and the top layer is the foundation to stabilize, and no pun intended, to stabilize patients who are hypermobile, because if you're not well, it's hard for you to engage in your healthcare. On the left, you can see I help patients identify their comorbidities. You've heard lots about mast cell activation, POTS, GI problems, urogenital problems, fatigue, sleep, and I help patients figure out how that relates to their hypermobility and what they can do about it, whether they need to see a provider or there's some self-care they can do. In the middle there, you see decreasing the central, peripheral, and autonomic nervous system sensitization. All of the previous speakers talked about pain and pain sensitization. If your nervous system is screaming, it's not going to tolerate much. And if you experience that everything makes you worse, you probably have a sensitive nervous system and we need to calm it down first. And then educating for body mechanics and posture, so that we're putting less mechanical stress on the body, because we do have fragile tissues and stress can damage us, okay? Once that foundation is there, then patients typically tolerate proprioceptive, body awareness exercises, motor control exercises, training to relax those muscles that might be guarding, stabilization, strengthening, muscle flexibility, and aerobic conditioning after that. And when PT fails, it's often because the PT jumped right in. It's like, oh, you're hypermobile. Let's get you stabilizing and strengthening. It's like the body's not ready for it yet. And then integrating into proper alignment and function, which is particularly important with the mouth because you cannot function without your mouth. And then managing flares. It's not a question of if you will have a flare, but when you have a flare, do you have the toolbox to manage it? Can you take care of your flares on your own? So a little bit of anatomy of the temporomandibular joint. So it is a hinge type joint, and it normally spins a little bit and then slides forward. And to allow that sliding forward, there's a disc in the joint. So right in there, that little white spot there is a disc, kind of like you have a disc in your meniscus, and that facilitates the sliding. And that's going to be important because sometimes that disc can go AWOL. Behind the disc, there are some elastic fibers, fascia, that helps to pull the disc back when it goes backwards. We've got a muscle that pulls it forwards, but the elastic fascia pulls it back, or should pull it back. When those fibers get stretched out, the disc goes AWOL, and we'll talk about that. It can lead to either clicking or locking in the joint. So that's one way the fascia can contribute to jaw problems, primarily related to the disc. And then we have the muscle and the myofascial tissues. So in this picture where they show the white shiny stuff, That would be fascia. There's fascia that surrounds muscle. It's inside the muscles. It helps to connect it to other structures. And so there's a lot of fascia in the muscles, and our understanding of that fascia has changed hugely in the past 10, 15 years. When I went to anatomy class, fascia is what we took off to look at the interesting things. Fascia is really, really cool. It helps the muscles to transmit their forces, helps things to slide, as you've heard already. There are a couple of really interesting things about fascia, though. Brianna talked about the myofascial sites. So when I learned about fascia, it was shrink wrap. It was just a completely inert structure. But we now know that fascia has these or muscular fasciocytes that can contract. Now, it's never going to lift a weight for you. It contracts very, very slowly, and not a lot. But when it contracts, it stays there. The other thing that's really interesting about fascia contracting is that it's not activated by the motor neurons that we can control to, move our body around. It's activated by our autonomic nervous system, right? So your stress system. That's why when we get stressed, we tend to tighten up. And places where we have lots of fascia, like our thoracolumbar fascia, well, interesting, when we get stressed, we tend to have a lot of tension back there. Fascia is slow to contract and even slower to relax. So once you're tense and that fascia is tight, now you don't have the muscular mobility anymore that you should have. And as we've heard already, fascia is really important for proprioception. If you don't know where your body is, it's going to be hard to control it properly. So some of the contributing factors to temporomandibular joint problems, so a bunch of the questions that have already been submitted is, do people with EDS hypermobility have more jaw problems? We are definitely at risk for a couple of reasons. One, we tend to have hypermobile jaws, right? So don't try this, but if you can fit 3 knuckles into your jaw, that's too much, okay? And so the jaw is unstable, it's going to wobble around, it's going to be pulling on the tissues, just like any other joint in the body, except we use our jaw like several thousand times a day to chew and to talk. Again, emotional stress will tighten up those muscles, which will pull it out of alignment and it won't function properly. If you are a mouth breather, that is a bad thing because the muscles that opens your mouth so that you can breathe is also the muscle that pulls that disc out of place. And if you're a mouth breather, that disc can't go back into place. It's just not going to stay there. Poor posture, habits like clenching and grinding, poor proprioception happens to the jaw just like it happens to other joints, and poor coordination or motor control, just like in other joints. It really isn't a lot different than other joints. I don't know why we tend to think that it's something completely different. Okay, so the connective tissue, this is a close-up or a closer-up picture of the retrodiscal tissue, so behind the disc. So right now in this picture, the mouth is pointing to your right. And so that's that disc that the jaw would normally spin and then slide forward, and the disc would come with it. If the disc is pulled too far forward because we have that muscle, it's called the lateral pterygoid muscle, it pulls the disc forward, which you have to do because the disc has to go with the jaw as it opens. But if that muscle's pulling too hard, then the disc will sublux in front, an anterior subluxation. And if it pops back and forth, then you'll have disc reduction or disc dislocation with reduction, click, 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 click. If it dislocates and stays dislocated, you may have locking, you may be unable to open your jaw, or if you're hypermobile, you may have only half the normal opening, but it's still a lot of opening. And also muscle spasm in those muscles of mastication, the chewing muscles can pull that disc out of place. So this is a picture showing the disc dislocation with reduction. So that's the click, click. We call it a reciprocal click because it clicks once when you open, and it's actually the disc popping into place when you open. And then when you close, it clicks again, the disc popping out of place. And I'm not going to go through the picture in detail. It is in the handout if you want to get the handout from my website. But it is kind of helpful to understand what's going wrong. And there's a move that PTs that we can do to test whether the disc is popping in and out. We call it a recapture. And I'll show you the instructions on another slide, where you can actually, if that disc is subluxed forward, you can actually go back and catch it and pull it back. And then you just try to keep your jaw relaxed and not open too much so it doesn't pop back out again. If you don't reduce, if the disc doesn't go back, you don't have the clicking anymore. So sometimes people say, oh, my jaw used to click, but it doesn't click anymore, and they're like happy about that. Sometimes it just means that the disc is completely dislocated now. It is aggravated by opening too wide, so dental work, mouth breathing, and it may or may not respond to conservative care. It's not always possible to get it back. It's not always painful, and if you're hypermobile, you probably still have plenty of opening. The myofascial pain, so these are myofascial trigger points, so muscle, myofascial, and the trigger points are areas in the muscle where the nerves connect and they get irritable and they cause referred pain that I'll show you in a moment. Each trigger point has a specific referral pattern. It's a super common cause of jaw pain and headaches as well. And remembering that fascia tends to contract with stress, these trigger points can be caused by mechanical stress to the tissues or emotional stress that activates the tissues, okay? And clenching and grinding, poor jaw posture, poor tongue posture, and cervical instability. So it turns out that if you have cervical instability, which a lot of people with hypermobility have, you will use your jaw muscles to try to supplement your neck muscles. Turns out that the tongue actually attaches to the deep neck flexors, and so some people actually brace their neck with their jaw. So if you have cervical instability, it'll tend to aggravate jaw problems. So these are the trigger points. We've seen these pictures a couple of times so far, but I'm going to take a little bit more detail. So trigger points will have referred pain patterns. So the X's are where the trigger point is. So if you were to poke at that, you might find a tender spot. And then the blue shaded areas are where the referral patterns are. And each muscle has a characteristic referral pattern. And these are in the handout. So if you want to get these, you can get them off my website. The masseter, which is one of the chewing muscles, and the temporalis, which is the other major chewing muscle, cause pain in, cause pain in the forehead, in the cheek, in the jaw, and toothache. They also cause other symptoms, so ringing in the ears, very common. Some people have been told, oh, nothing we can do about that. It's like, well, that's not true. There are several trigger points that cause ringing in the ears. The trigger points can cause toothache and sensitivity to heat and cold. I've had patients who had teeth pulled, and it's a trigger point. And so making sure if you have sensitive teeth, check for trigger points first. And if you feel like your teeth don't meet correctly, that they don't quite fit together, that may be due to the trigger point. Causes and perpetuating factors, so clenching, grinding, anything that's closing the mouth, dental work, holding your mouth wide open for a long time, stresses the muscles, forward head posture, and proprioceptive deficits. These are some other muscles. These are on the inside of the skull. You can't palpate these. So the lateral pterygoid and the medial pterygoid. The medial pterygoid is another closing muscle. The lateral pterygoid is the one muscle that opens the jaw and pulls the disc forward. These can cause mouth and throat pain, trouble swallowing, ear pain, sinus pain. Again, teeth that don't feel like they meet correctly, and pretty much the same perpetuating factors with mouth breathing being a major addition. If you're a mouth breather, your lateral pterygoid is working 24/7, pulling that disc out of alignment. So what can we do about it? Well, if you can identify the source of the pain, are you grinding? Are you a mouth breather? Is it the dental work? If you can identify what's aggravating, is it stress? Then trying to decrease those risk factors, okay? And making sure you're addressing the contributing factors, not just the symptoms, okay? So Botox can relax a muscle, but if you're stressed and you're clenching, it's just going to come back. So really trying to figure out what the contributing factors are. because trigger points are your body trying to stabilize something. And especially if you have neck instability and you've got trigger points trying to stabilize, you need to try to find the correct ways to stabilize your neck so that those peripheral muscles aren't doing the stabilization. Using caution with Botox. I know there's some controversy. There are experts, EDS experts, who can do Botox safely. But if they're not an EDS expert, be cautious about that, either for your TMJ or for migraines or neck pain, because it can make you instability. You're weakening that muscle that's trying to help you. So be very careful with Botox. So addressing perpetuating factors, so making sure you're breathing correctly, that you're not using your neck muscles to breathe. You're using your diaphragm. We've heard a lot about that. You're not mouth breathing. Working on posture, so forward head. Your neck and your jaw are connected to each other, and so if your neck posture is out of alignment, your jaw posture is out of alignment. Poor work ergonomics, bad sleep position, dental work. We'll talk about that in a bit. I have a whole bring to your dentist handout. Stress, anxiety, poor proprioception, and motor control. I'm not going to show you the YouTube, but if you are a mouth breather, watch it. It will change your life, okay? Mouth breathing will change where your teeth are in your mouth. It changes your neck alignment. It changes your throat. It changes your sinuses. It changes your tonsils. And it's... Okay, so posture affecting the jaw. You've heard a lot about posture already, so we want to avoid forward head or text neck. Tongue has a posture too, and we heard from a couple of people earlier, Dr. Schaefer and Christina Simonek, talking about how the tongue should be on the roof of the mouth, all the way on the roof, not just tiptoeing on the roof. Your teeth should be apart. They shouldn't be touching unless you're actually chewing. Avoiding flares at the dentist. I'm not going to go through this one check at a time, but a lot of people have problems at the dentist, and a lot of those problems can be avoided. So instead of just opening your mouth as much as you can, first of all, we often have twice as much opening as the average person, so the dentist doesn't even expect us to open that much. So just because you can doesn't mean you have to. And if you open and pull your jaw back, you're less likely to pull your disc out of alignment. There are a whole bunch of suggestions there. Some relate to having POTS, so don't tip the table upside down. Don't make me sit my head upside down if you have neck instability, etc. RTTPB is a mnemonic for remembering some good sort of TMJ hygiene. So relax, stop what you're doing, release your tension. We've heard a lot about that. Your teeth should be apart. Your tongue should be on the roof of your mouth. Your posture should be upright, and you should be breathing from your belly and through your nose. There are things that you can do to decrease inflammation and muscle spasm, the same things we would do in other parts of the body. There are some exercises. They should be specific to you and taught to you personally. You can do massage to the muscles if you have tension there. There's a lot of things that you can do yourself. Stress management, and sometimes a dental appliance. These are a few websites, and the slides are accessible to you, and you can access the website. Some things that my patients have said have been helpful to them. This is my disc relocation maneuver. So this is not evidence-based, but so far every patient I've taught it to says it helps. And again, I'm not going to talk you through if you do have a clicking jaw and you want to try it. You want to sort of have some peace and quiet where you can do it carefully. But the idea is that when you open, you get that first click. The disc is in place. You're going to touch tip to tip and then pull that disc back, and then try not to open your mouth for a little while. Good thing to do at nighttime before you go to bed. Dental appliances, I'm not going to talk about these. I don't know very much about them. There's a lot of controversy. This slide was approved by Dr. Schaefer, the dentist, who knows a lot more than I do. This just shows that there's research for all the things that I've said. If you have a sensitive nervous system, you need to calm this down. So central sensitization, temporomandibular pain. If you have a bunch of these problems, and people with hypermobility often do, you probably have a sensitive nervous system. You need to calm this nervous system down. Mechanical treatment to the jaw alone is not going to be enough. I do not have time for these slides. These are bonus slides because myofascial headaches are a big thing, and there's lots you can do. So I've got all the same kinds of information for Sternocleidomastoid, that is my all-time most favorite muscle. Feels like a migraine and a sinus headache put together. And with that, in summary, people with hypermobility are vulnerable to more jaw problems. There's a lot you can do to take care of your jaw, to protect it, to keep it well, and things that you can do to help when it already hurts. And fascia has a lot to do with both the disc problems and the myofascial problems. So